Part 2 of the therapy of infectious and parasitic disease. Drugs that weaken the bacterial cell wall. We're first going to discuss penicillins. Penicillins are active against a variety of bacteria. They belong to a beta-lactam family of antibiotics because they have a beta-lactam ring as part of their structure. And beta-lactam antibiotics will weaken the cell wall, cause the bacteria to take on excessive amounts of water, swell up, and rupture. This is how penicillins work. And penicillins can be narrow or broad spectrum, and they can be used to treat infections by many types of bacteria, like I mentioned before. Now, penicillins are particularly ideal because they have an active mechanism against a variety of different bacteria, but they have low toxicity, so they don't hurt us. Remember, selective toxicity, that term. Allergic reactions, though, are the principal adverse effects, but they are pretty safe and they have high efficacy, and this is why penicillins are widely prescribed. The true mechanism of action of penicillins is to destroy the cell wall. Okay, so the cell wall itself is rigid, it's permeable, it's mesh-like, and it lies right just outside the cytoplasmic membrane. But inside the cytoplasmic membrane, the osmotic pressure is really high. And if it wasn't protected by this rigid cell wall, which really prevents expansion of the cell, bacteria would take up water, swell, and then burst. Well, we want this to happen. So penicillins weaken that cell wall, and it's going to cause the bacteria to take up excess water, rupture, and burst. So generally, penicillins are bactericidal. And they are able to weaken the cell wall by two different actions. They inhibit transpeptidases, and they disinhibit or they activate autolysins. Transpeptidases are enzymes that critically are needed for cell wall synthesis. Specifically, they will catalyze the formation of that cross bridge between the peptidoglycan polymer strands that form the cell wall and give the cell wall its strength. Autolysins are bacterial enzymes that will cleave bonds in the cell wall. Bacteria will use these enzymes to break down segments of the cell wall so that they can actually grow, and that they can expand, and that they can divide. But if we can simultaneously inhibit transpeptidases and activate autolysins, the penicillins will disrupt the cell wall and promote active destruction. So this is in combination what will result in what we call cell lysis and cell death. We have to remember that penicillins are active only against bacteria that are undergoing growth and division. Now, because our cells lack cell walls, this is again why, because of selective toxicity, they're only going to disrupt bacterial cells and not our own. Okay, so bacterial resistance to penicillins is determined by three different things: inability of penicillins to reach the target, inactivation of penicillins by bacterial enzymes, and the production of PBPs that have a low affinity to penicillins. Okay. PBPs are penicillin binding proteins. PBPs, penicillin binding proteins. Now, there are certain bacterial strains, collectively they're called methicillin resistant Staph aureus or MRSA, that have unique mechanisms of resistance. Production of the PBPs, okay, which again, PBPs, what do they stand for? Penicillin binding proteins. The production of these penicillin binding proteins with a low affinity for penicillins This is what makes MRSA so difficult, because they developed this inability by acquiring genes that code for low affinity PBPs from other bacteria. Okay, so not only will they not work really they will not work with penicillins, but other beta-lactam antibiotics as well. Okay, so MRSA, penicillins, beta-lactams, they don't really mix well together. These resistant Staph aureus win. And this is because of altered penicillin binding proteins. And though we had just a short introduction of Staphylococcus aureus, let's talk about it just a little bit more. Now, Staph aureus is a gram-positive bacterium, and it colonizes the skin, it colonizes the nostrils of people that are healthy, me and you. But infection involves the skin and soft tissues that cause abscesses, boils, cellulitis, impetigo, all because of Staph aureus. But more serious infections can occur, they can develop into Staph aureus of the lungs, the bloodstream, and these can cause sepsis and become fatal. Now, like the other pathogens, Staph aureus has developed resistance, and because of this, some drugs don't work as well. Now, when penicillins were first introduced in the 1940s, all of the Staph aureus strains were susceptible to it, but penicillin resistance quickly emerged, and it's because we were using penicillin. And we owed this to the bacterial production of penicillinases. In 1959, the resistance was overcome with methicillin. We used a different strain. The first penicillinase resistant penicillin. But by 1968, these strains became resistant to methicillin. We now have highly resistant bacteria known as MRSA. They're resistant to not only methicillin now, though, which is obsolete, but also to all the penicillins and even most of our cephalosporin class. So the basis of MRSA, just as a review, the basis of MRSA resistance is this acquisition of genes that code for PBPs that have very low affinity for penicillins and very low affinity for cephalosporins. And we have these resistant strains, which were just at first limited to healthcare facilities, like long-term healthcare facilities and hospitals, but now we have MRSA out in the community. Okay, so there's two distinct types of MRSA. There's the healthcare-associated MRSA, and then we have the community-associated MRSA. And healthcare-associated MRSA is more prevalent, like 80%, and then 20% community-associated MRSAs. 1968 is when we started with the healthcare-associated MRSAs, and it wasn't until 1981 that we were first combating the community-associated MRSAs. Okay. Also, healthcare-associated MRSA infection is generally more serious and harder to treat than the community-associated type MRSAs. How do we transmit healthcare-associated MRSA? We know it's through person-to-person contact. Usually it's between a healthcare worker and a patient, but we do have some risk factors. Not everyone will get MRSA just because they come in contact with another person, but if they also have advanced age or recent surgery or hospitalization, they're on dialysis or they're in intensive care, and even if they've just been on antibiotics for such a long time, if they have a catheter or they live in a long-term care facility, their risk for acquiring healthcare-associated MRSA is really, really high. And we have to use clinical practice guidelines by the Infectious Disease Society of America to help us to understand how to treat methicillin-resistant Staphylococcus aureus, or MRSA. So what do the guidelines say? They stress the importance of selecting the right drug based on where the infection is occurring. Think about the age of the patient and what drug is actually sensitive to the pathogen that we need to combat. So for instance, for complicated skin infections like soft tissue infections, in adults we use IV vancomycin as one example. And for children, IV vancomycin is also the drug of choice. Now, there's some other drugs that we can use for adults, but I just like to remember vanco or vancomycin can be used in adults and children as the preferred drug. Preferred drugs for pneumonia, so let's say someone gets pneumonia from a MRSA, is IV vancomycin, linezolid, and clindamycin. Okay, these are based on the clinical guidelines. But because the strains of MRSA are mutating and they're multi-drug resistant, many of the antibiotics now are not effective, like the tetracyclines and the clindamycins and the beta-lactam agents, obviously, except for ceftaroline. But these are not able to combat MRSA anymore. Okay, so MRSA, IV, vanco, adults and children, very common. Penicillin Gs are the prototypes. They are narrow spectrum, and they were the first penicillins that were available for us to use. And we often just leave the G out when we say penicillin. It is bactericidal to a number of gram positives, but also some gram negative bacteria as well. You might also heard penicillin G referred to as benzyl penicillin. The pharmacokinetics, as far as that goes, absorption, it's available as 4 different salts, penicillin G. Okay, so we have potassium penicillin G, procaine penicillin G, benzathine penicillin G, and we have sodium penicillin G. These salts all differ with respect to the route of administration and when we're thinking about the time and course of action. With all of these forms, the salt dissociates to release the penicillin G in its active component. Most often, we can give all forms of penicillin by IM route or intramuscular route, but it's important to think about the different salts that are absorbed at each of these routes. When we have absorption of potassium and sodium types of penicillin G, the absorption is going to be rapid and the blood levels are going to peak about 15 minutes after we inject. But with procaine and benzathine salts, they're absorbed more slowly and they're considered repository preparations. When benzathine penicillin is administered actually by IM, the penicillin G is going to be absorbed for weeks and the blood levels are going to be persistent. However, they're going to be very low. So the preparation has to be considered. It's useful only against highly sensitive organisms like T. pallidum, which is a bacterium that will lead to syphilis. Penicillin distributes well to most of our tissues and our body fluids. Whenever there is inflammation, though, it becomes a little bit more troublesome. Penetration of meninges into the fluids of joints and the eyes is poor. By contrast, whenever there is inflammation, entry in the cerebral spinal fluid or the CSF, the joints and the eyes is actually enhanced. And this will permit treatment of infections caused by these susceptible organisms. So it's best when there is no inflammation. Penicillin undergoes minimal metabolism and is eliminated by the kidneys. And when it is eliminated, it's primarily unchanged. Renal excretion is about 90%, and it involves the active tubular secretion. The other 10% will be a result of glomerular filtration. In our older pediatric population and adults, the half-life is pretty short, only about 30 minutes. Renal impairment causes the half-life to increase very dramatically and may necessitate a reduction in the dose. And so when you are trying to dose penicillin G and you have a patient with renal impairment, look for the renal dose. Patients with high risk for toxicity, so renal impairment, but also someone that is really acutely ill or someone that's very, very young or very, very old, you want to monitor kidney function as well while this patient is on penicillin G. The major side effects of penicillin G are if there is a side effect at all, you'll see prolonged but also reversible sensory motor dysfunction. Okay, especially after accidental injection into a peripheral nerve on accident. You might also see neurotoxicity, which means the patient might have seizures, confusions, hallucinations, if the levels of penicillin are too high in the blood. Inadvertent intra-arterial injection can produce severe reactions like gangrene, necrosis, and sloughing of the tissues, and we want to absolutely avoid accidentally administering into the artery. So be very careful with this IM injection. Penicillin G is the least toxic, though, of all the antibiotics, and it is among the safest of all medications. So I just wanted to tell you what the worst thing could be, but let you know that it's generally pretty safe. Also, though, there are certain adverse effects that can be caused by compounds that are co-administered with penicillin. So, for instance, the procaine component of procaine penicillin G, the salt procaine with penicillin G, may cause bizarre behavioral effects when procaine penicillin is given in too large of a dose. When we give large IV doses of the potassium penicillin G and we give it too quickly, we can actually cause hyperkalemia because the potassium is attached to the penicillin G. Remember what happens to someone with hyperkalemia. We're worried about dysrhythmias and cardiac arrest. Also, if we give too much of the sodium penicillin G, what do you think happens to that electrolyte? We're going to have another imbalance. So we should be very careful with sodium penicillin G. We don't want to use it with patients that are on a low sodium or sodium restricted diet. Let's talk about penicillin allergy a little bit more in depth. We're going to do that on the next slide. Now, penicillin allergies are pretty common. It's the most common cause of drug allergy. And between 0.4 to 7% of patients that receive a penicillin will have some type of allergic reaction. And it can be very minor, but it can also be life-threatening. So minor like a rash. Okay. And what we need to consider is how did they develop it in the first place? What are the type of reactions that could occur with penicillin? With most allergic reactions, there's no direct relationship between the amount or the size of the dose and the intensity of the response that it elicits. But if you've had prior exposure to penicillin, because that's what's required for an allergic reaction, your responses may occur in the absence of prior penicillin use because patients may have been exposed to penicillin produced by fungi or to penicillins present in foods of animal origin, like in our meats, like antibiotics that are found in our meats, right? So because of this cross-sensitivity, patients that are allergic to one penicillin should also be considered allergic to a different type of penicillin. Few patients, like 1%, display cross-sensitivity to cephalosporin, but it's worth asking the question and it's worth being careful, right? So, are you allergic to penicillin? Yes. Have you ever been told you were allergic to cephalosporin? No. Okay, I might still prescribe a cephalosporin, but I'm going to be monitoring very closely. Or, oh yes, I had anaphylactic shock to penicillin. Well, I might just, if there's another drug that was correct for that bacteria or that infection, I would probably hold off on cephalosporin. Okay. The use of cephalosporins really depends on the intensity of the allergic reaction. So if that penicillin allergy was mild, I might still use it. Think of that it was probably going to be safe. Again, if it was severe, I'm going to avoid it. Also, patients that are allergic to penicillin should actually be encouraged to have a medical identification bracelet or some type of alert, maybe some information on their phone that they are allergic to penicillin and what that allergic reaction was. So, what are the types of allergic reactions? They're classified as either immediate, accelerated, or delayed. Immediate means like 2 to 30 minutes, right? Really quickly after the drug has been given, you see something. Accelerated means 1 to 72 hours, and delayed can actually occur within days and weeks. The immediate and accelerated reactions, these are the ones that are going to be mediated by IgE. Okay, very important. Mediated by IgE. Anaphylaxis is an immediate hypersensitivity reaction, and it is more frequently going to occur when penicillins are used in any other type of drugs. The incidence of anaphylaxis, though, is still extremely low. Only about 0.004% and 0.04%, so pretty low. But if the reactions occur, we are worried because mortality is really high when a patient is in anaphylaxis. What's your primary treatment? Epinephrine. Sub-Q, IM, IV. You're also going to watch for respiratory restriction, dysfunction. You're going to provide respiratory support. Ensure that you are treating this anaphylaxis very quickly. And then you're going to observe the patient for at least, at minimum, 30 minutes after the drug injection, okay? Especially if they have a history of these type of reactions. Or until the risk for anaphylactic reaction is passed over. How does someone develop penicillin allergies? Well, remember the development of allergies to small molecules as a class. Now, small molecules such as penicillin and most of the other drugs are unable to induce antibody formation directly. But to promote antibody formation, these small molecules have to create a bond, a covalent bond to a larger molecule. And usually it's going to bind to protein. These combinations of small molecule is referred to as the hapten. The hapten protein combination constitutes the complete antigen that will then stimulate the antibody formation. It needs to attach to a larger protein. Therefore, the hapten that stimulates the production of penicillin antibodies is rarely intact penicillin itself. It has to form from the degradation of penicillin, and as a result, these penicillin antibodies aren't really directed at penicillin itself, but the various penicillin degradation products that are left over. Someone that has a penicillin allergy when they were younger may not have a penicillin allergy later. It decreases over time, and so that's why you want to ask about their allergic reaction, how long it was before it happened. Just because they had it in the past doesn't necessarily mean that you will still elicit that same intense reaction again. But if your patient says yes, they have a history of penicillin allergy, you could. If you know that they have an infection or susceptibility to something that really needs penicillin, you can do a skin test. And this can be used to assess the current risk for penicillin. What do we do in the skin test? We can inject just a little bit of the allergen intradermally and just watch to see if there's any local type allergic response. Very small amount. The positive test would tell us that there is IgE antibodies, and this can actually mediate into a very severe penicillin allergy. But if the skin test is negative, then anaphylaxis from penicillin is pretty unlikely. However, Do you feel comfortable doing the skin test? It can be actually dangerous, right? Because if someone has a severe penicillin allergy, the skin test itself can precipitate a larger response like anaphylactic reaction. I don't do this skin test. They tell me they have this type of allergy. I'm not going to mess with penicillin. I might be very weary about cephalosporin. I will call infectious disease and get a consult, or may call the pharmacy to see if they can help me to prescribe a more appropriate medication, or antibiotic in this case, for that person. In any case, if you are going to do this type of testing, you must have epinephrine and respiratory support. Okay? And in most cases, some of the clinics that you'll be working at will not have the respiratory support needed. Current guidelines recommend that the skin testing has to occur with 2 reagents. One's going to test for the major and minor determinants of this penicillin allergy. The minor determinants are less common and they mediate most severe penicillin reactions, though. Okay. So, as a general rule, just avoid the penicillin if someone says yes. Maybe think of cephalosporin. However, think about, do they have anaphylaxis or was it just a little rash? Okay, so that 1% could have that cross-sensitivity to cephalosporin. For many of these penicillin type allergies, patients with infections can also be considered for vancomycin, erythromycin, clindamycin. These are pretty safe and effective alternatives to patients with penicillin allergy. Okay, let's talk about the rare. A patient with a history of anaphylaxis may have this life-threatening infection, like maybe think about enterococcal endocarditis, and you don't have an alternative to penicillins that are going to be effective for the endocarditis. So in these cases, you have to think about the risks and the benefits. Do the potential benefits outweigh the risk of penicillin therapy? And if they do, then you need to consider using penicillin. But to minimize the chances of a patient having an anaphylactic reaction, you need to administer it according to what we call a desensitization schedule. So how do we do this? Initially, just small doses followed by 60-minute intervals, and then we progressively move into larger doses until we can get to the full therapeutic dose and watch and see that there has not been any reaction along the way. These desensitization procedures are not unrisky, right? And again, if you're going to try this, you're not doing it in your clinic. For most of us, we are doing it in a facility that has good respiratory support. Preferably, we have a respiratory therapist and access to epinephrine. Now, penicillin V, also narrow spectrum, is also sometimes called penicillin VK. It's very similar to penicillin G in most of the areas. The primary difference is the acid stability. Penicillin V is stable in stomach acid, but penicillin G isn't. And because of its acid stability, penicillin V has actually replaced penicillin G for oral therapy. Okay, so we use penicillin G mostly for IM. Now we also can have penicillin in an oral form. Penicillin V has to be taken with meals. Okay, so or we'll get some GI upset. Then we have a drug called anti-staphylococcal penicillins. This classification still follows under, and nafcillin would be your prototype for that classification. Okay, so what are penicillinase resistant penicillins, or the anti-staphylococcal penicillins that we were just referring to? Well, if we altered the side chain of penicillin, let's say you work for a pharmaceutical company, you're a chemist, you're creating a group of penicillins that are highly resistant to activation by beta-lactamase. But here in the US, there's 3 drugs that are available: nafcillin, oxacillin, and dicloxacillin. So the nafcillin that you saw, that's a prototype. And these are very narrow antimicrobial spectrum drugs, and they're only used against those bacteria or strains of staphylococci that are penicillinase producing strains, like Staph aureus and Staph epidermidis. Because most strains of staphylococcal produce penicillinase, these penicillinase resistant penicillins are what we like to use for all the staphylococcal infections. So it's not without some consideration, though. Think about drugs that should not be used against infections caused by non-penicillinase producing staphylococci, because they're less active than penicillin G against these types of bacteria. Okay. There is the problem of staphylococcal strains referred to as MRSA, which we've discussed, and they indicate the lack of susceptibility to methicillin. Again, this is now obsolete, but all of the penicillinase resistant penicillins. We also have here the broad spectrum penicillins, like the aminopenicillins. There's 2 broad spectrum penicillins that we can use: ampicillin and amoxicillin. And we are pretty knowledgeable about these medications. You see them all the time: amoxicillin, ampicillin. Both have the same antimicrobial spectrum, just like penicillin G, but they have an increased activity against certain gram-negative bacilli, like Haemophilus influenzae, E. coli, Salmonella, Shigella species. These broaden, so broad spectrum, penicillins. Mainly, they're due to an increased availability or ability to penetrate this gram-negative cell envelope. Both the drugs, ampicillin and amoxicillin, are readily inactivated by the B-lactamase, and so they're ineffective against most infections caused by Staph aureus. Ampicillin and amoxicillin would not be the choice in that situation. Ampicillin was the first broad spectrum penicillin that we use clinically, and it's useful against Enterococcus, protease, E. coli, Salmonella, Shigella, influenza. But the most common side effects are rash and diarrhea, and it's pretty frequent with ampicillin than any other penicillins will you have like rash and diarrhea. Now, if rash occurs, you should evaluate the rash and think, is this a non-allergic rash or is it related to a hypersensitivity reaction? Ampicillin can produce non-allergic rashes as well in about up to 10% of children. And usually this type of rash will go away in about 10 days and as early as 3 days after initiating the ampicillin. You can give it by mouth or IV. If you're giving it by mouth or for oral therapy, ampicillin is going to be preferred. The dosages for patients with normal kidney functions you can see here, and if you have a renal impairment, then you are going to use the renal dose and the dosage should be reduced. We also have the extended spectrum penicillins like piperacillin, tazobactam, and this is a drug that is only available with IV. And most times, if you need to use this drug, you have to go in to a hospital setting to be administered this drug. Sometimes, if everything else is stable, you can go to outpatient clinic and get this drug transfused.